Okay, well, why don't we start? So I'm Scott Podolsky, and I'm honored to get to welcome back one of our own, Dr. Kimberly Sue. Dr. Sue is a assistant professor. I'll be formal in my introduction. Is assistant professor of medicine with the program in addiction medicine in the division of general internal medicine at Yale. She also serves as an attending physician at the Central Medical Unit, the APT Foundation, which provides primary care to patients receiving methadone and other substance use treatment services. She supervises fellows and trainees within the Yale Addiction Medicine Fellowship Program, and she serves as an attending physician on the hospital-based Yale Addiction Medicine Consult Service. Such work has been deeply informed by Dr. Sue's training as both a clinician and medical anthropologist. She completed her MD and PhD in anthropology here at Harvard, working with so many people in this room, including Arthur, Byron and Mary Jo, Alan Brandt, David Jones, Salman Khashoggi, and of course, Paul. Dr. Sue would develop her dissertation into her remarkable 2019 book, Getting Wrecked: Women, Incarceration, in the American Opioid Crisis. Her book, based on extensive ethnographic research, examines the sexual violence shaping the lives of the women with opioid use disorder she followed here in Massachusetts, the conflicted and harmful dual status of jails and prisons as sites for both punishment and apparent treatment, and the limited commitment of current approaches to both confronting such structural forces and to the potential uses of harm reduction strategies. Amidst our Department of Global Health and Social Medicine, Dr. Sue considered Massachusetts part of the globe, stating in her book her conviction that, quote, social suffering close to home is an enterprise just as complex as studying it abroad. After Harvard, Dr. Sue would go on to complete her medical training at MPH, internal medicine and primary care, with a clinical focus on substance use disorders and addiction medicine. She would then, among other things, become the medical director of the National Harm Reduction Coalition in New York and serve as attending physician at the Rikers Island Correctional Health Services, including through the early months of the COVID pandemic, about which she's also written eloquently. She joined Yale in 2021, continuing her work on the treatment of our most vulnerable fellow people and patients. And today we'll get to hear her speak on the backlash against harm reduction for people who use drugs, notes on failing U.S. drug policy on the Frontline clinic. But before she starts, I know that Byron wanted to say a few words as well.
So I'm also just really happy to have Kim come and talk about her work. I want to, many of us worked with her on her thesis and then saw it turned into the remarkable book that I nominated for a book award, and therefore I just want to read a few lines about that. But first, from a student who read your book in one of our classes, who said, Getting Wrecked explores each aspect of the question through the lives of heroin-using women as they cycle through treatment centers, courtrooms, jails, prisons, and hospitals in the Boston area. We all remember that field research. And with whom Sue worked over 2 years of ethnographic fieldwork as an MD-PhD candidate. Broadly, Sue endeavors to understand how inequality becomes embodied into physical bodies, and that's in quotes, how medicine, punishment, and drug use became bound up in politics and in the realm of the social, and how doctors and everybody else can intervene in this inequality and in these bindings. And I think it's a nice statement from a student and a reminder of the readability and really the helpfulness of this work. I didn't hear whether you mentioned explicitly, but I remember. So Kim has, of course, worked on the one hand as the medical director of the Harm Reduction Coalition, but also spent a lot of time in the prison system and in Rikes during COVID, for instance, doing work there. So she's worked both inside and outside, and with really the same kinds of. So rather than any other summary, I'm going to read just a couple of other lines. So this book is a powerful critique, but not a simplified one. It is not one that moves to a quick narrative of sort of critical theory, because it recognizes the complexity. So none of this is simplified to exemplify a clear narrative of critical theory. We hear how women at some times are grateful for prison as a respite from the struggles of living on the streets, selling sex for drugs, or trying to negotiate housing from pimps and abusive boyfriends. We hear of the power of heroin and other drugs to overcome the best intentions when these women leave prison or a treatment program. We're reminded of how many women are incarcerated for merely possessing and using drugs, how sentences are greater for women than men, and the history of this phenomenon. We're reminded of the near impossibility of real employment for anyone, but especially women who have a history of felony, particularly when associated with drug use. There's no simplification here. And so it is really classically in the genre of superb ethnography in refusing to use theory to simply create a simple narrative. And I know that that runs through her experience of working on the streets, her experience of working in the prison system. And we're really delighted to watch how her career has moved over these years.
Mm-hmm.
So
Thank you so much,
delighted to
Byron
have
and
you
Scott.
here.
So thank you all for inviting me, and I'm really excited to present you new material for what I would hope would be a second book. So bear with me with some of these ideas as we iterate through them together. This is something that I've been thinking about for a long time, and I see as an evolution of the work that Scott and Byron talked about. So I think part of what I'm going to lay out for you also accords a bit with my training and sort of my evolution in that. And I think you'll be able to see some of that. So take notes for feedback for this book. Okay. The thing doesn't work. This thing?
It didn't work in the
Right.
previous meeting.
Oh, okay, okay.
It's a new one and everything.
Okay.
That's exciting.
So how do I,
And then you can just click.
can't.
Is it working for your computer?
Sorry,
Is it working for your laptop? Or-
it was being controlled.
Oh, okay.
I think what's happening is
Okay. Okay.
who knows what
Okay,
that
great.
was.
Okay, so complex, nothing to disclose here. Okay, so I start a lot of my talks talking about sort of this idea of the war on drugs, and these are two historical pieces that situate the ways in which substance use in many ways has always been inflected with structural racism. So on the left is a poster for a play called The Queen of Chinatown that was produced in 1900, written by Joseph Jarrow. It was produced in Cincinnati. And as you can see, some of the imagery, there's Chinese immigrants. They are abducting white women to drug them with opium, torture them, and sell them into sex slavery. There's also a lot of imagery that's associated with rats, and at the bottom it says hurled by high binders through the rat pit's double trap. So this play in some ways, or this poster in some ways, epitomized some of these fears that go throughout US drug policy, of this fear that people of color, in this case Chinese men, would entice or lure white Americans into substance use and lack of control and lack of moral from their moral high ground. So that's one. And the second is a New York Times article from 1914 that reads, "Negro cocaine fiends are a new Southern menace." So some of the article actually goes into, I'm just going to read you some of the article and think about the racialization of cocaine and blackness. So one part of it is titled "Proof Against Bullets." But the drug produces several other conditions that make the fiend, quote unquote, a peculiarly dangerous criminal. One of these conditions is a temporary immunity to shock, a resistance to the knockdown effects of fatal wounds. Bullets fired into vital parts that would drop a sane man in his tracks fail to check the quote unquote fiend, fail to stop his rush or weaken his attack. It goes on a bit more, and they give an example. They say, the following day, the chief exchanged his revolver for one of heavier caliber, yet the one with which he shot the Negro was a heavy Lieutenant Townsend Wieland. Lieutenant Townsend Wieland, who is an authority on such matters, recently declared this gun was large enough to kill any game in America. And many other officers in the South who appreciated the increased vitality of the cocaine-crazed Negroes have made a similar exchange for guns of greater shocking power for the express purposes of combating the fiend when he runs amok. And finally, which iterates on, my book, as far as the thousands who have already formed the habit are concerned, there is little choice in remedies. Once the Negro has formed the habit, he is irreclaimable. The only method to keep him from taking the drug is imprisoning him. And this is merely palliative treatment for when he returns inevitably to the drug habit when he is released. So I do start off with this frame because a lot of what we'll see in future, I'm not necessarily going through all of the laws, but a lot of it is based on this profound racism and xenophobia. So you're familiar with the Nixon, who declared the formal war on drugs in 1971. Obviously, we've had numerous drug laws before that as well that led to incarceration, but this leads to our current kind of peak. And the idea that I was interested in is the sort of thinking about what is this war on drugs and how how we can theorize it. So anthropologist Jared Segan wrote that the war on drugs is a non-totalizable assemblage constituted by global militarism, state-based surveillance and control, carceral political economics, biopolitical therapeutics, and international and national inequalities. And in the US, I put a lot of sort of our ways that we fund this. We particularly have continued to have a lot of drug law arrests that are racialized of people of color, as well as poor whites. But there's a lot of money that we spend on prohibition. A lot of money is spent to fund the DEA, and a lot of money is actually spent to transfer militarized carceral equipment to local police. And so this is where a lot of our money goes. And just for some context, which I'll talk about, when we in the United States embraced the idea of harm reduction, the first grants were for a total of 30 million, right? And we have 3.3 billion going to the DEA. So some more sort of statistics about, what does the overdose death crisis look like in the US? Month after month, year after year, we have been going up. I just looked at some of the data. This is the most recent data from CDC that puts us at 105,000 deaths in the estimated 12-month period, but that puts us at about 1 million people since 1999 who have had overdose deaths. And I wanted to show you some of the statistics out of Connecticut. And I was looking at the Connecticut office of the chief medical examiner, some of their data. And this is a smattering of some of the deaths from 2023. And you can really see that, well, a couple things you can actually see, and I'd be interested in the historian's perspective in this room. But we have actually evolved into not just a quote opioid crisis, but there is, we talk about polysubstance use in addiction medicine, and really this is very, very common. It's common that people are young. Okay, so if you look at their ages, you can see that people are in their 20s, 30s, 40s, 50s, 60s. So young, right? And many substances. So this is something that I think the anthropologist can look at, as sort of the evolution of why people are doing so many substances at once, has that really changed? Were people always really doing so many substances, or is, and why, with some increased sort of toxicity here. So we know that this is also disproportionately affecting people of color here, but obviously many white populations as well. But I wanted to specifically point out who is at increased risk for death and harm. And this is some data out of CDC from 2022 that showed the overdose death rate among Black men is 7 times higher than white men who are over 65. Black people during the pandemic experienced the largest rate increase of overdose compared to other racial and ethnic groups. For Alaska Native American Indian women, overdose death rates were 2 times higher than white women in sort of the reproductive age bracket. And so these gaps are super important to pay attention to.
So these don't look, on this table, it doesn't look that much.
Right. I mean, I think there's a delta change here from 2019 to 20, and it's really, look at the delta for over time. I mean, it's really important to keep our eye on. And so a couple things. So we know that the majority of people with, let's say, opioid use disorder are largely not in treatment. So when they put together this report, they found that like 1 in 10 Hispanic people had reportedly received substance use treatment, and 1 in 12 Black people had been able to access treatment, which is pretty abysmal, but the rates of people engaged in treatment are low anyway. So the things that we care about, that we study in the clinic, mistrust, distrust, access to pay, to certain payers, insurance, all of those things come into play as we think about overdose death rates, as we think of who has access to what's protective. And, it's not just opioids. So, as you saw from the death data, a smattering of the death data from Connecticut, there was a lot of alcohol. And I did want to mention this, though my topic is, this talk is not necessarily about alcohol, but harm reduction more broadly. You can apply this philosophy to not just opioids, but alcohol. And really, we have seen a surge in deaths related to alcohol, an increase in deaths during COVID of 30%. I was seeing people with severe liver disease being admitted in the hospital, and really thinking about what happened during the pandemic, and can we roll these back? Can we think structurally about the stress, about substance use, about what drinking does for us, about sort of depression, anxiety, and keep track on that. And we know that the death gap, it's always disproportionately been men who die, but the death gap for women related to alcohol-related diseases is closing, which is not good. And binge drinking between women is very common now. I took care of a young Latina woman who died. I think she was 29. She had no idea why she was jaundiced. She went into hepatorenal failure, was on dialysis, and died. I mean, and that it's not uncommon for us to be taking care of people who are much younger, and alcohol definitely was and is part of this picture. And so I also want to frame that a lot of this gets framed around overdose death, and as social scientists, I wanted to broaden out ways that we can think of what are other harms, because we fixate on this number, 108,000 people died, so many people died, but there's so many harms of both substance use and lack of access to compassionate care. I've mentioned many of these things. There's many sort of clinical things, and there's many sort of social things that I wanted to that we'll talk about. But it's important to not and there are many people that die of an overdose, and there's many people that survive an overdose, right? So it's much more common to survive. So what is the afterlife of people that survive 1, 2, 3, many multiple overdoses? So when I graduated residency, I I had I had some idea, but I really did not truly understand the idea or the notion of harm reduction. But this was my journey into it, and this is how Harm Reduction Coalition defines harm reduction, and they say utilize a spectrum of strategies to reduce the negative consequences associated with drug use, sex work, or other behaviors, and including but not limited to abstinence and other techniques. And what's really important about this slide is that many people in the treatment community, many people who are in abstinence space, maybe AA or NA, really really shun people who are using, and harm reduction really embraces anything that improves your life, and really embraces people who if and many people, old veterans of the harm reduction community will say, I wanted to use drugs, but I could only live with. I wanted to use meth in a controlled way. I wanted to drink in a controlled way, but I absolutely could not. So many people endorse abstinence, and so it's a big tent. And I'll talk a little bit more about this, but sees itself as part of a movement, and really sees itself as part of looking upstream, much like we do in social science, looking upstream at these large social forces that lead to people's oppression. And people in harm reduction really see substance use on a continuum that can range from nothing to chaotic and persistent. And sometimes it's interesting as a clinician to think about where people think they are and where they want to be. And we, in general, moving people down here, but even if up here in a safer way, we would consider a victory or a small win in harm reduction. I took care of a guy in the Yale emergency room who had basically blacked out and had some consequence from taking too much Vicodin from his dentist and drinking on top of it. And I said, where do you, what's your relationship to your substance? Which is the most anthropologic thing to ask, and no other doctor cares about, where do you want to be with your substances? What's your relationship like? And he was like, well, I just want to get high and watch the Three Stooges. He did not want to be here. He did, and I kind of like to create that space where people can tell me that honestly, and because that's what he's going to do. And I said, well, how do I get you there and not see you again in the emergency room? So how do we reconcile this and do it more safely? So that's kind of the harm reduction mentality. And these are many definitions. And this is the one that the National Harm Reduction Coalition had come up with, which is a movement based in a political liberatory framework that shifts power and resources to people vulnerable to structural violence. One of the harm reduction groups in Chicago says any positive change. And this one from Harm Reduction International, which I really like, so a UK-based group. Harm reduction refers to policies, programs, and practices that aim to minimize negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. So it really frames it in terms of, the large, big scale, drug laws are what makes people unsafe. Prohibition is what makes people unsafe. And, using a not sterile syringe. And this is what I teach in the clinic. I said, okay, there are practical things we can do in the clinic. So there are little things we can do in the clinic, but I don't want you to forget that people who use drugs, it's part of a movement, that a social and structural movement. So, Alan told me this morning that he's been lecturing on this for many years now. So I have one slide on, just one slide on history. But you can correct me if I'm wrong, but a lot of, initially, if we're talking about syringe exchange, began in the 1980s in the Netherlands. with people who injected drugs. They call themselves junkie bond, re-embracing the name, working with nurses and healthcare workers to do syringe service programs. And in the United States, Tacoma, Boulder, New Haven were many of the places, and many other places, the UK, Australia, Switzerland, Nepal, and Brazil. And we knew, we really associated with HIV and in the 80s. And this is a photo of from the New Haven Journal about John Parker, the Johnny Appleseed of syringes, who was a Yale School of Public Health student who was doing syringe services and syringe exchange before it was legal, all up and down the New England coast. So this is an example also of what I consider the broad tent of harm reduction. And remember how I said little h, little r, so things we can do in the clinic on a clinic level. And when I first came to Yale, someone in the emergency was like, how can you let people know that harm reduction is more than just naloxone or Narcan, because it really is so many other things. It's having a place to have housing where if you don't want to be using meth to stay awake in a park where you were sexually assaulted, housing would be what would solve that. So, from a harm reduction perspective, being able to be in a place where you could use substances and not get kicked out would be, example of harm reduction. So people definitely associate naloxone and syringes with harm reduction. People don't necessarily think of, having low barrier medication treatment. We now have 2, maybe a couple more coming on board, overdose prevention centers in New York City. Those are places where people can take pre-obtained drugs from the street and use them under supervision of medical people or peers and receive immediate access to overdose services. And, they have had not one death in those facilities, utilized by, 20,000 people, and no deaths, and increased access to things that people need. Safer drug use, we talk about fentanyl test strips, if people have heard about those, and drug checking. So we have a machine, a patient left me 4 bags last week to go check on the FTIR machine. So I took them over to the syringe service program to get a detailed, chemical analysis of what was in them. Was xylazine in it? Was this heroin? Why was she having a bad reaction? So getting a FTIR read followed by a GCMS read. So these are some examples of harm reduction. And so why do we need it? I made this argument when I went to Yale with my boss, David Filene, in the New England Journal, and we basically laid out what we're doing is really not working. We have 105,000 people dying of overdose, let alone, not what I said, people not just dying. So what we're doing is not working. Criminalization and carceral approaches have significant harms, as we know. And implicitly is that we are very uncertain as a society, as an American society, with just our acceptance with mind-altering substances, that it's a social fact that communities all over the world have always found a way to become intoxicated or mind-altered, and just recognizing that and figuring out how do we recognize it, how do we minimize it if it's having bad effects, and how do we make it safer. And HHS did name harm reduction as a pillar strategy during the Biden administration. And it's one of 4 pillars: prevention, harm reduction, treatment, and recovery support services. So it was named as a pillar strategy, but was not funded as a pillar strategy. So when I talk about sort of the backlash against harm reduction, I want you to think about these 4 areas, because how are these areas interplaying? So I'm going to take you to my clinic and talk to you about my patient, and my patient's given permission for me to use his photos in this talk. And we published a case actually with him in it last year. So Mr. Dennis is a pseudonym, but he's a 69-year-old history of opioid use disorder. He had this history of this tonsil squamous cell that was treated many years ago. He comes in to show me a wound. So the way in which he actually comes to see me is, I was in a visit with his best friend, and I was talking to his best friend about these new wounds that we're seeing. And he's like, oh, you gotta see my friend's arm. So basically, he brings in this guy and he's like, is this it? I was like, that I think is this. So that's how I made time to see this new patient concerning for a drug contaminant in the fentanyl supply. So it's gonna be very graphic. So I just wanna let you know, if you don't wanna look, please look away. This is his arm. That arm on the left is when I first saw him. And these are evolutions of his wound over time. So he actually had biopsies because he had this history of the cancer. You know, the biopsies were just, you know, pretty plain. Like there was really, you know, just some, you know, there was really nothing infectious. So, you know, it was really not totally clear what was going on with him. And he wanted me to take care of him. And he said that he had not seen a doctor in a long time because of the hostility that he faces, a Black man in his 60s who injects drugs. And he only came back because he heard that I was nice. So he you know, it was a very interesting thing. Then I looked at him a little bit more closely and I was like, have we met before? We had actually met before, a year before, in the consult service at the hospital. So I had met him when he had an infection of his back, an osteomyelitis discitis of the back, and he had walked off of methadone treatment. So basically he had been on some dose of methadone 80 or something, and then just, you know, a certain point right before his infection, which was probably injection related, you know, we were consulted for pain, and we were understood that he had walked off methadone. So he was in a ton of pain. He was really upset. And obviously he would need a higher dose of opioids than someone who wasn't used to taking opioids. And I had an addiction medicine fellow who is a Jamaican American, who is a Black man. And Mr. Dennis called him a narc, okay? And so we had this incredibly sort of tough, you know, and then we went to like I was very new to New Haven and did not really understand sort of what the role Yale New Haven played in New Haven, and he felt the hospital was racist. He felt that the hospital wanted him to purposely suffer in pain. And my doctor, the fellow working with me, you know, said that he felt that he was being treated as a Black doctor in a traditionally white space, and like an Uncle Tom, so to speak, and he was like betraying sort of the people, and then a year later, he kind of apologized. He was a gruff man, a very funny man, and he kind of apologized after the fact to the fellow and to me, and I took care of his wound. And I learned a little bit more about his history, which I felt was relevant. He started heroin when he was 14. His sister's boyfriend actually was the first person to inject him when the boyfriend came back from Vietnam, and he liked it. He had worked his whole life for the city and also for the homeless shelter. And he had tried medication for opioid use disorder for some periods of time. And preferred heroin and always paid his bills and was never incarcerated, sort of by the grace of God. And when I meet him, he's doing 2 bundles, which is 20 bags of fentanyl intranasally and an IV. And he also continued to inject into the wound, which is kind of important. And I sent off for xylazine, which is a new contaminant we have that is causing these wounds, and it was positive. But I started to think more about this wound, and I'm thinking through his case, and there's just so many things that really, that I started to think, how are our policies, like in what world do we live where he would much rather play Russian roulette with 20 bags of fentanyl than go to a methadone clinic? You know, what is that? Is what about the methadone clinic, the daily observed dosing, the being treated like a pissant by the security guards? Like, you know, he would much rather deal with and risk significant harm and death and ongoing use from fentanyl dealers than from me, or, you know, from the healthcare system. You know, I think the surveillance and the carceral nature of the opioid treatment clinic, he'd endorsed a lot of feelings of racism and disregard for his pain and suffering as a Black man in America. And he really wanted old school heroin. He just wanted the way it feels, the way it drips down his throat. Fentanyl felt cold, it felt clinical. Heroin felt warm, it felt like a hug. And he did not like fentanyl. He did not want it. And so I said, I'm thinking about doing this trial where I get you some IV heroin. Like, I was actually thinking at the time about doing a Dilaudid, you know, hydromorphone trial. And I was like, I want to do that. You know, like I would do, and if he had that, he wouldn't have these wounds. Like, he really wouldn't have these wounds. So, you know, we know that Switzerland has access to opioid agonist treatment, injectable opioid agonist treatment. We know that that's available in Canada. We know it's available in many places, and it's not available here in the United States. And he desperately wanted it. And he was not able to access sort of harm reduction addiction services. And interestingly, he worked as a truck driver and had sleep issues, and he would have preferred to smoke cannabis, but because it shows up on a drug toxicology, he would rather do fentanyl. So these are sort of the ways in which prohibition has led to our patient being in a place of much more significant risk of harm and death. And he is the age of 50 and 60-year-old Black men are the people that I worry most about for overdose death because of our statistics. So he, you know, so it was really difficult. I got him on methadone, and ultimately after a certain point, he was like, you know, I'm going to walk off and just deal with fentanyl because that's what I prefer to do. I don't want to come daily. I just want, and so I stopped seeing him.
Can I ask you a question about it?
Yeah.
What are the odds he's someone who would have said yes to Sublocade, especially since he wouldn't want to come every day, for example?
He had a bad reaction in the history, like he precipitated himself by taking it on the street.
But we know why.
We actually had tried to initiate him in the hospital when I was with the fellow on buprenorphine because we wanted anything to protect him, and he did not like the way it made him feel. But it's a good thought. It's a really good thought, and would significantly decrease his chance of death. Yeah. So that case has sat with me for many years, and I continue to think, you know, what if these things that could be in place could have prevented his wound and sort of saved his life? And I think, you know, harm reduction services, this holistic care. I did some of his primary care for the first time in many years. And so I wanted to give you a smattering of like some of what the variety of things that we can do in harm reduction. This is from one of the 2 overdose prevention centers in New York City. This is from On Point, where they supervise not only injection use, but also smoking use. Different syringes, people will come in and ask for different size syringes to inject. In New York City, they'll ask for biggies, biggie smalls, everything corresponds to a certain gauge. And here I put a crack stem. So I have a patient who drinks alcohol, has an alcohol use disorder, opioid use disorder, and a cocaine use disorder. And she burned herself, her leg, and got a cellulitis with a stem that she bought at the local bodega. And if we don't include stimulant users, we are not being comprehensive. Stimulant deaths have been on the rise for the last 5 years, meth and cocaine. And we really need to be comprehensive. And I got into a lot of nighttime arguments when the White House, someone from the White House called me and said, what's the evidence on crack pipes? Like, why should we support those? And, there's no direct literature that says if you fund these, then people won't get HIV. I mean, and syringes were needles were very clear. But this is more about engagement. It's more about trust. It's more about meeting people where they're at and sort of not, in some way, syringes are barely acceptable, but try giving these out in the hospital. So I can give syringes out in the hospital, but I can't give crack, well, we don't call them crack pipes, stems, cocaine, stems to smoke cocaine in the hospital because of the particular stigma around these devices. And I told you that I took some of my patients' baggies to do some drug checking. So this is another strategy that's available at the overdose prevention centers, and it's available around the country in certain syringe service programs. And basically, I took the fellow on our first day when they got this new machine, and we were pretty excited to try it out. So basically, people, you can see my bad handwriting, but people would call us, they say, that's a Xanax bar from the hill. And then we had a little mortar and pestle, and we would crush it up, put a grain's worth of it in the machine, compare it to certain spikes that are in existing chemical libraries, and try to understand what was in them, both to give them information, and it's not really a point of care, so you can't say, what's in this, and I get it to you immediately, but we understand what's in it in the New Haven ecosystem. And we understand the baggies, and we understand what they're called. And it was called a Xanax bar, but it was like, there was no benzodiazepine in there. It was just sugar, So it's like, nothing is what it seems. Nothing is what it seems, so very little is what it seems. But this one is an example of a drug checking out of Rhode Island. So they would log what it's sold as and what is found and what they actually found. So this was sold as heroin or dope, and it was fentanyl, parafluorfentanyl, xylazine, cocaine, tramadol, lidocaine, levamisole, acetaminophen, acetylfentanyl, isotonitazine, quinidine, heroin, phenacetin, all of these, right? This was sold as Adderall. It was methamphetamine, ketamine, and cocaine, right? So drugs out there have changed, right? I mean, basically people are using, we don't even know, what they think, what they think is what, this. So really, like, if you look at various drug overdose crises in US history, we are dealing with sort of the fentanyl just takes the potency to this level that we've just never reckoned with before. You look at heroin in the 60s, you look at, Mother's Little Helper, you look at these other kinds. I mean, fentanyl just takes everything to 1,000. So, some, drug theorists have talked about the iron law of prohibition, meaning that, when we restrict one thing, or people are going to find and innovate ways in the setting of inelastic demand to something smaller, more potent, more powerful, more deadly. So we don't have a lot of heroin. We still do have a little bit of heroin in Connecticut and Massachusetts, for example. And my patient was like, this is heroin, and it actually was heroin, but fentanyl is in like 80-90% of our supply. And a lot of this, you listen to just the news every morning and talking about the border, and this is a consistent theme that fentanyl is coming across the southern border, or fentanyl. Something just 2 days ago said, why don't we have a humanitarian approach to the people in the U.S. who've lost someone to overdose? Fentanyl is the problem coming across the border with these people, people coming, and it's really been associated as, this. I mean, we've seen this historically with this xenophobia, this idea, and it has not stopped. It has not stopped coming across the border. The Mike Johnson, the House Speaker, said, the Biden administration's open door to illegal immigration is flooding America with fentanyl, human trafficking, violence, killing our citizens. killing our citizens. They have the power to stop this, but they won't secure the border. So we know that the fentanyl is coming in from airports. So, we know it's coming in from many other places that are not just the southern border, and it's coming in, and supply side regulation has not really changed. We get like 2% of what comes in through customs. And, I've been thinking about how fentanyl is different from iterations on previous drugs of choice that Americans have had. I put up this is your brain on drugs piece, and this is a DEA recent one pill can kill campaign. And, some of the things that have made it different are the potency, the risk of death. What's actually really interesting here is a lot of the rhetoric around fentanyl has changed too. So you'll see the DEA introduced 2 years ago this idea of fentanyl poisoning, which is interesting because parents or people, what we're talking about being poisoned instead of overdosing, and the idea was that, this person was a victim, this person was poisoned, this person didn't die of an overdose, they died of a poisoning. And it sort of separates people with fentanyl deaths into people who deserved to die and people who with addiction who made a choice. So Ron DeSantis said, there's a lot of these opioid deaths that are really poisoning people with fentanyl. I've met a lot of moms and kids who lost their kids and they weren't drug addicts. They just did something they didn't know was necessarily in it. This rhetoric is sort of creating it's sort of a racialized narrative too, of like a white child, a white teenager who is poisoned and a, Black person who uses drugs who made a choice, and so it's pretty disturbing. There is increasing legislation for distributing or drug-induced homicides. So the idea that you gave someone this and you now need to go to jail or prison. There have been a couple of cases. Michael K. Williams from The Wire, the actor from The Wire, had an overdose on fentanyl, heroin, cocaine, and his last year, a 71-year-old, largely illiterate man who himself has a substance use disorder, in and out of the prison system, was convicted for 30 months. And David Simon, who wrote The Wire, was like, Michael K. Williams would not have wanted this to be the case. He explicitly struggled with addiction. He talked about these sales. He would hope that you would treat Mr. Matchy with redemption and grace, love, and leniency, and rather than put him into the system that, like, we made this whole show about the dangers of this system. There was a very famous trans activist, Cecilia Gentili, who died a couple months ago of an overdose, and the people who were prosecuted were young people of color, and they're often people who are friends with, supplying, low level. I mean, they're not getting these kingpins, they're getting just people who are also, and we know from like Angela Garcia's work, other people's work, that it's an act of care to like keep someone out of withdrawal, and like you're not necessarily trying to, but these are, so we still have these laws, but basically they're like, we got these dealers, but they're people of color who are often using themselves. So it's very disturbing. And I was part of this amicus brief. So these other things are happening in Ohio. A pregnant person with a substance use disorder was charged with corrupting another with drugs, the fetus. And she was sentenced to 8 to 12 years in prison. She has a substance use disorder, and she was charged basically, probably an untreated substance. So I was part of the amicus brief, and and the appeals court reversed the decision, so she was freed. But these are happening all over the place. So the criminalization, we are really swinging into this criminalization in a very dangerous way. And I'll talk a little bit about Oregon. Where are we on time? Okay, on time? Yeah, okay. So, had anyone heard about that Oregon decriminalized drug possession? Okay, so in 2020, Oregon got on the ballot a referendum to decriminalize possession of all substances. So it wasn't like cocaine or hair, it was all cocaine, hair, meth, small amounts of drugs. And they said, we're gonna fund, what we save on this thing into treatment system, and we're gonna use our cannabis money. We're gonna fund all this into the treatment system. And it really, I'll tell you a little bit about it, but basically, 2 months ago, they recriminalized drug possession. So really, I felt that harm reduction wasn't really given the full chance. What they would do if someone was using drugs was they would give someone a citation and a fine, kind of similar to Portugal. And someone could be basically call a hotline and do a health needs screening. They could they were supposed to be given treatment rather than incarceration. And what actually happened during the pandemic, during this time period, was the pandemic happened. COVID eviction protections ended. Oregon and Portland, particularly, I don't know if anybody know how much it costs to live in Portland. A lot of people became homeless. Street drug use was an issue. And fentanyl actually arrived in Oregon late. So the West Coast got fentanyl late. The East Coast had it for a long time, but the West Coast had tar, heroin, and some other stuff. And their surge in deaths skyrocketed. So if you look at Oregon and Washington State, super red. They went up leagues because they had just seen a new, very potent, the shift from heroin to fentanyl is very dramatic. And major crime was decreasing, but they decided to recriminalize it. So another thing that was really interesting was the treatment system in Oregon is the second worst treatment system in the country. So you can't get access to treatment. So what reformers argued was that without harm reduction and these sort of decrim measures got thrown under the bus, while these other systems that take time to develop and increase capacity for providers, for medication, for methadone, for the technical assistance is required to do buprenorphine, Sublocade, all this other stuff was just not there. It was not done, and it could not have happened in 4 years. And so, I testified on I testified in some committees in Oregon, and the rhetoric, this question I put in here of people feeling safe. And the idea of our public spaces is really important. And I think it's worth reckoning because I would present all this data. Nobody cares about data. I say, oh, if you have like a syringe service program, it decreases syringe litter. Like, in New York City, you call in an hour and they'll have picked up like 1,000 any syringe you see, someone will come pick it up within an hour, within this radius. And then someone comes up and is just like, well, what about this person, using drugs in my park, which is just on the beach and it's a beautiful place, so that has to be reckoned with, that the feeling of our public spaces, and how do people perceive themselves? What do people perceive as safe? And paradoxically, like if we had more places for people to use indoors safely, there would be, we hope less people using in parks, right? But again, nobody wants those. And so where are people going to go? They're going to go to their house and they're going to inject alone and die. That's what Connecticut looks like. That's what Massachusetts looks like. So that's what happens. People are shamed, stigmatized. They don't, they may use in a Dunkin', but the majority of deaths are at home where people use alone in the comfort of their own home. So there's just not places for people to receive in 5 or 10 minutes the service that the naloxone that will kick those opioids off and save their life, which is, a super, huge tragedy. And, I talked about the harms of criminalization in my book, the risk of overdose after involuntary treatment and after leaving prison and jail. And this is happening all over the country. So Philadelphia, the new mayor, you've probably heard of San Francisco. Each of these is probably its own dissertation and it's sort of the local politics of substance use. Not $1 is going to syringe service program, says the new mayor of Philadelphia, Cheryl Parker. And she's cutting off the syringe service program of $1 million, basically gutting the syringe service program, which does not have other sources of funding, not significantly. And what's interesting about Pennsylvania is only it's not legal in the state. Syringe service is not legal in the state, but Ed Rendell did it in 1992 and authorized it, and she's no longer authorizing it. So we're swinging back into lack of sort of a more conservative approach, and Pittsburgh also has it, but the rest of the state does not have it. And one study in the Journal of AIDS had estimated that Prevention Point averted 10,000 new HIV cases over a period of about 9 years, which would be something like, over the lifetime of people with HIV, something like $1.8 billion in lifetime savings. In fact, this city went on record saying there will be decreased syringe distribution and an increase in HIV cases as a result. The city director of HIV health and the interim health commissioner said, we are clear and anticipate there may be some spikes, so we have a plan for that. So acknowledging that you're going to have an HIV outbreak, and we know that syringe services were critical to the prevention of HIV. So it doesn't, what's frustrating for me, and as a clinician, as someone who believes in evidence, that's just not in play here. So what does the anthropologist have to say about what's going on here? What does the historian have to say about what's going on here? Because it's not about what we know. And I put up here, in 2010, I lived with Philippe Bourgois' team in Kensington, Philadelphia, which is a very large open air drug market, which became the neighborhood that Cheryl Parker said she wanted to clean up. She put curfews on all of the bodegas. She really wanted to improve this feeling of safety that I mentioned in the Oregon side. Is like how people don't feel safe. So people would go into Kensington and basically make these exploitative YouTube videos. And this, and they just video people just on drug, video people in their worst circumstances and tour you through like sort of, the very stigmatizing language, zombies. I mean, they're often referring to fentanyl with xylazine or trank dope, which I showed you the wound from before. It makes you almost like anesthetic, you might have tone, but you're really, it's very different from just fentanyl. And has 2.4 million views in 3 months. And every time I talk to a patient, they've seen these videos. So like, we are just not engaging in the ideas, like we are just not engaging with people we're not effectively engaging with people with our message, and people are out there engaging with people in a much more, in a way that is speaking to people. And we are not doing a good job. So this is a case, another patient that I met on, also in the methadone clinic, but also I met at New Haven in the hospital, a young woman who was found to be HIV positive. And it would take you back to the fact that we know, because of HIV outbreaks in the United States, that this is from injection drug use. So this is a cluster that developed in 2014 and 15 of 180 people who tested positive for HIV. There's a family doctor who wrote a book about it, about receiving HIV positive case after HIV positive case. and this is from the New England Journal, but this shows you the network of how people shared syringes, and there was some sexual contact. But all of the gray is syringe sharing. And the interesting thing about this is they sent in sort of a sociologist, social scientist after the fact to analyze like what happened. And then you learn some really interesting things, which were that this was an outbreak related to not heroin or fentanyl, but to pills, to oxymorphone, a long-acting oxycodone type pill. It was meant to be tamper resistant, which we all know is not, everything's tamperable. The pills were really expensive, and this is a town that was dirt poor. People could not afford, so $80 a pill for 80 milligrams. People would buy a quarter of it, $20, and they'd all go into the same cooker. So they cook the drugs, very viscous, very thick, very difficult to cook down. Fentanyl dissolves in water like just whatever. This is thick, viscous, tamper resistant. So they kept going in, quartering it. They'd share a pill. They'd all get HIV, right? And they'd go back again because they paid so much money for it that they want a rinse shot. They want to put the water in the cooker again and inject again. So we have multiple injections related to people not having syringe services are illegal. Mike Pence, okay, then they become legal because of this outbreak. So that's kind of what we know. And then now we go to Philadelphia where we know this is going to happen. Mm-hmm. And this is an addiction doctor in Canada in Halifax that I think really helps us understand the role of social science and the role of understanding policy, because we could easily blame that on like, oh, you used a dirty needle, you used an unsterile needle, you didn't have access to that, you didn't wash your hands, right? But these are individual level behaviors, and what we care about are the micro and the macro. We care about the criminalization of drug use. We care about, why someone's not carrying naloxone. I actually sent harm reduction kits, to people who were community health workers, who were trained to work with people leaving prison and jail, and they got them, and they're like, what am I gonna do? What if someone finds this in my purse? These are people who have left, who are formally employed in the research apparatus, and they are dealing, their job is to kind of work with people who are coming out of prison and jail. And yet viscerally, like, these things have a history, syringes have a history, pipes have a history, the stigma associated with them is important. Someone walking down the street said, I won't carry naloxone because they'll think I'm a drug user, even though I could save your life. I'm a Black man in Philadelphia and I could get arrested for that. So that's because of so this is a lot more than just getting people syringes or naloxone. Like, why do people use the technologies that we have or not use them? And that has to do with stigma, it has to do with acceptance, it has to do with policies and laws at the housing level, sober houses, at how people get treated in the hospital, international drug policy. So I like this scheme because it takes us away from just like the blame associated with one, you just used a dirty syringe, it's your fault, you got HIV. It's like, this is the system in which, people are living. And, I've begun to like shift some of the ways that I'm thinking about this into my own research and thinking about, as all of these tough things are going on, as there's been a backlash against harm reduction, which I don't think is fair, because I think the other pillars are also not, appropriately fleshed out at this moment. But I've also been sort of trying to think about doing research and building power with people who use drugs, people with lived and living experience of drug use. And harm reduction has never been a panacea. I've never said that it's going to cure all of our drug ills. And even if we had access to, even places like Connecticut, where we have tons of syringe, Massachusetts too, increased access to syringe service programs, to meet people's material needs. we still might not see we might see some reduction in overdose deaths, but we need to, it's not a panacea. We need to increase access to methadone and buprenorphine. We need to increase these other pillars as well. Recovery supports. We know the isolation is killing. We know that it leads to these things. So I'm very careful to say, like, this is not like harm reduction is going to cure the entire overdose death crisis. It's not.
Just so you know, it's 20 minutes
Okay, great.
till we have to get out of here.
Oh, okay, great. So I'm gonna stop. But I just think you missed my theory slide. Oh, you missed my history slide.
Definitely do that.
But I just think we need to be doing more. We just need to be doing more than we've ever done. And we need to be innovating. We need to be, the research that I'm doing with people who use drugs, like I'm just trying to co-create with them and have more meaningful research. I can send you the slides, but this is not necessarily something new. And David Musto, I was rereading his book, and he's like, we're really quick to just have impatience. David Hertzberg's like, we're really quick to have this relentless forgetting, and it's a historian's task to bait against that tide. And this is very systemic, as Elizabeth Hinton has pointed out. And these are, and sometimes, purposeful. And so this is, what I think we can do in social medicine. I think from some of the previous work I've done, people who use drugs are actually not only left to die, but are actually objects of hostility, hatred, revulsion, and it's okay to say that now. So what does that shift mean? I think about overdose deaths as stupid deaths, as Paul Farmer had said, and I've pointed out sort of why people shouldn't die of overdose. And I think we just need to do way more than we've ever done in social medicine to address these questions. It's not about evidence. We know what we need to do, but what is the realm in which people are living, the policies in which people are making, and what are people reacting to? We have to attend to those if we're going to make any dent in improving the care of people who use drugs. I will stop.
Thank you so much for that.
Yes.
And we're open for questions. Anyone?
I just want to ask about the relationship with marijuana legalization.
Mm-hmm.
A kind of obvious question, but like, how did that happen? Is it actually dangerous?
Mm-hmm.
Is it a model?
Mm-hmm.
Et cetera.
Yeah, I think it's not only cannabis or marijuana legalization, but also the discourse on psychedelics as well too, which are increasingly becoming, accessible, available, and studied, and accessible to certain classes of people. I think that cannabis regulation, it's a whole nother thing. I mean, there's a lot of, once it's been regulated, obviously the states are getting tons of cannabis money. I think, if you look at the national surveys on drug use and health, cannabis rates among young people have not increased. There's all this fear that, increased access to legal, is going to increase it for the young people. It's always, and that's not necessarily proven to be true. I think that different states have done it differently,
Is the quality issue?
It's not, it's totally not standardized, but it is regulated, if you come to Massachusetts or you go to New Jersey, what you're going to get is completely different quality and strength and potency. So none of it is really, nothing is, things might be checked by your state health department, but they're not checked or standardized in any particular standardized way on a federal level. I think it is interesting, and states have done it so differently and so disparately that I think it's interesting. It definitely, New York State, for example, still has a lot of underground, they didn't roll it out fast enough. So people still go to these other, they still get it from the street, so to speak. I think it is a model. And what's also interesting is psychedelics. I mean, the amount of money, the amount of ways in which people of like a white, middle class, educated, who want to use Michael Pollan, they want to use psychedelics, they want to use them safely, and this is how we're going to get it. And we're going to put this money in, and we're going to get it approved through these studies, and we're going to have access to what we know is, you know, psilocybin, and we're not worried that fentanyl's in it, right? So, you know, David Hertzberg writes about regulation, like we've regulated drugs in the past, and we really, you know, the problem with is we're never gonna, you know, how do we get what people who use drugs call a safe supply? You know, Canada was doing some fentanyl prescribing, you know, hydromorphone prescribing, like people know what that is. When you take an ibuprofen 200 milligrams, you think it's ibuprofen 200 milligrams. And like, how did that come to be, you know? How do these drugs come to be? Or when you drink alcohol, you drink a shot, you know, you think you know that it has this much in it. And that is just, like I showed you the drug check, it's just wildly not that. So the idea of how do we, the logical conclusion in some ways would be how do we create, you know, these safer alternative treatments.
Dr. Su, thank you so much for your presentation. For everyone else who's here, Dr. Su was my attending just about 3 years ago. Early May, I was a fourth year med student at Yale, and I'm now a third year medicine resident here in primary care, wanting to do addiction medicine in some form. So I'm just so thrilled to be here. Very formative in my trajectory. My question to you is, it's, as an anthropologist, I gather you asked just about every one of your patients, how did you get into using drugs? And as their PCP, that also kind of probably informs how you think about their other kind of like general medicine care. Some of my research, I'm interested in people who start using drugs, specifically opioids, because they experienced inadequate pain treatment. And I'm starting to see in a very small cohort of like, 1,300, not a huge cohort, 1,300 people were basically Black patients who experience unmet opioid preference for an acute pain episode. Later on are way more likely to report using opioids from a non-prescribed source, which obviously is not evidence of chaotic drug use, but it is an introduction to the illicit market in some shape or form. And I'm curious how much you see that in your clinical practice among people who are already using.
Yeah. I mean, it wasn't necessarily the case with the patient that I presented, but there was untreated pain. And I think that disalienation from the formal healthcare system that Black people may face is a real, you know, your hypothesis that it's easier to get on the street. I mean, that was the case of George Floyd, right? I mean, he had an opioid use disorder, back pain, street fentanyl, right? And so, you know, as an anthropologist, thinking through those structures of alienate, you know, lack of access, lack of insurance, distrust, you know, many people that I would meet at Rikers, many Black patients that I would meet at Rikers had never been offered, you know, sufficient pain relief, sufficient, you know, just did not feel that they had sufficient general medical care generally, let alone access to medications for opioid use disorders, but in moments of sort of pain relief. And then you know, Helena Hansen's work, you know, you have, you know, you also can see some white patients who have had liberal access to multiple surgeries and have had liberal access to to non-street opioids and have developed, you know, substance use disorders through that pathway, which is interesting and important. Are there?
You know, yeah, Kim, I'm thinking that you're preaching in the sense of the wrong audience here, because the issue is not really for us. Is harm reduction the way to go? You and Alina Hansen made it clear, and many others made it clear, of course it's the way to go. The question is really the backlash. What about the backlash? And what can we do about that? And I think, in a way, learning from Portland is particularly important, because that backlash was not just a politicized backlash, as Portland remains much a Democratic city.
Mhm,
Okay, it's not just the Republican
mhm.
backlash.
San Francisco too.
Yeah, San Francisco too. It is
Philadelphia.
middle class. It is middle class people.
Right.
Being upset with the way that harm reduction is, well, I don't know if it's upset with the way it's actually done or the portrayal of it, the way it's
Mhm.
portrayed.
Mhm.
But we ought to be thinking about it, and you've had such experience in this. So what do you take to be the ways that we could do harm reduction differently than it was done in Portland, so we don't get that backlash?
Mhm. I mean, there's innovative programs that have spun up in the last couple of years. One is a mail-based program. So there's no sort of honeypot, so to speak, of one place where people go. They mail it to you, so they mail supplies to you. That in a way decentralizes one place from being the place where people hang out. The methadone clinic that I see patients at is 4,000 patients, and the main one called Congress, I didn't even go into New Haven, but the last mayor, a Democrat candidate, sent a mailer out. I tried to get it together for this talk that was like, his whole issue was against our methadone clinic. It was a quality of life thing, you know, like, so he would put a podium up in front of our methadone clinic, get one reporter, and one guy with a bicycle on his way to methadone would stop. Nobody was there, but he would write op-eds against our clinic. You know, it has some traction for some people, right? And what is that? You know, I think it has to do with, you know, well, methadone, people, like I was talking to David about this earlier, but it was like, you know, people haven't seen people recover enough to just get their regular, you know, colon cancer screening. Like, I take care of people in their 50s, 60s, 70s on methadone. I didn't even know they're on methadone. Like, and they're totally recovered, you know, they're just, you can't tell the difference. I would just never have known. You just don't see, you know, we have to, the YouTube video of zombies, like, I have so many people who've recovered, who've been able to go see their mother, who've been able to live their lives through harm reduction, you know, who've really been saved by it. And you don't hear those stories. We need to, you know, have narratives that have emotional complexity and that help people understand that people and I hate to say this, but with the opioid overdose death crisis, it's sort of thinking, okay, like, you know someone, and like, not all those someones are the same. You know someone who got access to treatment, but you don't know someone that went to jail, you know, but you do know someone, you know, so like, how do we create that collective buy-in where we all kind of know someone and we feel like they're good people?
We need our media and medicine masters to take this on.
Yes.
Yeah, really.
Uh-huh.
I was wondering if you could talk about like the intersection with the homelessness
Yeah.
and substance use. You touched it's come through like as a thread through many slides, but I think on the different times you've touched on it, it's been in kind of different roles.
Yeah.
And I was wondering, you know, yes, you acknowledge that we need to have housing
Right.
for there to be harm reduction.
Right.
But in what role is the lack of housing either driving the use in the first place or exacerbating the use for people who may have already have a substance use disorder, or is it just making it more dangerous because
Right.
you know?
Right. I think there's all of those things. I mean, it was a very interesting experiment when in COVID hotels here in Boston and San Francisco, people went inside. You know, there was like a lot of people were inside. There was a lot less street homelessness and people were being offered the services that they needed. There was alcohol harm reduction programs in San Francisco delivering, you know, nips to people so that they wouldn't have seizures and die. I think that, you know, people that are experiencing street homelessness, you know, really, in general, tend to have, you know, a lot more chaotic use. I think that people who, when they go inside, can really, you know, sort of might not have to contend with what you have to contend with on the street, violence, the threat of being, you know, robbed, assaulted, all of those things. and the public nature of it, people don't really necessarily want to use in the street and would much rather, the people that use the prevention center, you know, nobody necessarily wants to use there, but people would rather use in a park than and be saved than be you know, dead somewhere if they used alone. It's really complex, and there's also complexities to housing people who used to be on the street, because when they housed a lot of people during COVID, you know, there were some people who died because of isolation and use that was alone. So the problem that we were trying to innovate with was thinking about, you know, people are not used to being like in the room by themselves, you know, and are using the same way, but just no one is there to save them. So I think it's, I mean, the fact that homelessness is on trial now in Supreme Court says a lot in the sort of the criminalization of, in the lack of sleeping outside essentially, and not even necessarily doing substances, but there's a lot of complexity to it, I think. I had a patient who was homeless who was trying to get into a program, and he, you know, raged because of the access to the shelter system, like threw something in his hotel and got all of these injuries, you know, because of the terrible housing system.
Yeah, I'm just thinking about, you know, your presentation, which is just fantastic. But I feel like you have identified an area that reminded me of the young Paul Farmer going to Haiti. And why did Paul go to Haiti? Because he had realized it was the poorest of the poor.
Yeah.
No one was doing anything.
Yeah.
And I think you've located, you know, a largely domestic problem.
Yeah.
That these are people who have been fundamentally dehumanized.
Yeah.
So that the data doesn't mean anything
Right.
anymore,
Right.
because the othering is so profound and so powerful that the idea, well, we could save these people, we could bring them back to health, is almost outside of the
Yeah.
conceptualization
Yeah.
of how to think about medicine and health.
Right.
And you have certain personal characteristics that emerge in the ethnography, that you are totally non-judgmental. You see the value in these individuals and
Yeah.
the population they represent as
Yeah.
being as fully human as any patient.
Mhm.
But that is typically not the way
Right.
they're seen.
Right.
So it makes the obstacles really high. I could tell one quick anecdote. I taught a course just before the pandemic
Mhm.
on the opioid epidemic
Mhm.
for graduate students, but few undergraduates. And, you know, I was asking, like, well, with HIV, there was a lot of activity on campuses about what we should be doing, how we can protect ourselves and others, sympathy for needle exchange programs and so on. So the students decided they would collect all the data on naloxone and opioid sudden deaths, and that just like for AED kits, and this is wasn't their idea, it was in the literature,
Right.
you know, for AED kits, let's put
On the wall.
naloxone in the AED boxes. A lot of these boxes, they're very highly regulated and they're required by law. You have to have a certain number of them per building that has a certain number of people. When you open them, a lot of them call 911 immediately. So that's a good thing, because if you had an opioid overdose, you would want to call 911, but you would need to have naloxone available. So they went to the Harvard Health Service and they presented all their data. They sent it to the provost, you know, why don't we do a simple, relatively inexpensive thing, put naloxone in the AED boxes? And the Harvard Health Service has denied their appeal to do that. And I said, even if it was just symbolic, because some people say, well, you know, that's not where people are gonna overdose and so on. But as a symbolic act,
Yeah.
the AED boxes all over the Harvard campus they're not epidemiologically well thought out, because it's a very young population. Like
Unlikely
very
to have
few
sudden-
people
yeah.
have heart attacks in our
Yeah.
Harvard houses.
Yeah.
And, you know, I said to them, why has Harvard rejected this very clear evidence-based,
Yeah,
proposal? And I think the reason really was, they said, first of all, there's not opioid use in the Harvard community, which is false. But, I think we want to identify Harvard
Yeah.
as having
Yeah.
a heroin or
Yeah.
opioid
Yeah.
problem.
Yeah.
And for me, it was about sort of identifying
right,
less visible stigmas
right,
and hatred towards the other.
right,
And I think that, it's a delivery problem, but it also has, in addition, it's, can we get HIV drugs to people who really need them? But this is the ultimate test case of, the meaning of othering.
right,
And it's deeply embedded in biomedicine,
right,
that, when we expand buprenorphine accessibility for physicians, they don't want to take the short course. They don't want to be delivering buprenorphine because they believe that those patients in their practices, primary care doctors, will be disruptive and harmful to
Problematic,
their well-being.
right.
So I think what you're doing is so important, but I'm trying to think about strategies, like I take a statin now. And like, that is a form of harm reduction.
Yes, it is,
And I wonder if broadening the notion
Right.
of harm reduction
Right.
beyond,
Right,
because so many things, I have a lesion taken off of
Yeah.
my skin,
right.
and the reason is it's harm
Harm
reduction.
reduction. Yeah.
And I sometimes wonder about medicalization
Yes,
and expanding
yeah.
these definitions versus the kind of exceptionalism
For
that
substance
it,
use.
so I just don't know, but I'm curious about your thoughts about it.
No, I
Sorry
think-
to have talked for.
Yeah, no, I mean, I think it would be, it's really important, and I guess the follow-up question is, in our biopolitical form of governance, have people who use drugs always been the abhorrent other? Or has that always been the case with previous drug crises and epidemics? And like, what about this is different? What about fentanyl is different? And is it just more potent and deadly, or is it, I'm struggling with that as well. And why have we sort of allowed, the discourse is abject hatred and not just like, I will ignore you and let you die, but I hate you and you don't deserve to live, you deserve to die.
I thought your slide of the man's arm is a kind of critical data point in your whole talk.
Yeah,
Because, the anticipated revulsion or disgust or,
right,
dismay.
right.
And that kind of represents, in a single slide,
Mhm,
the sort of social psychological
mhm,
elements
Mhm.
of stigma.
right.
Yeah, see, this is really, stigma is totally inadequate as the framing
Yeah.
of this. And this goes beyond social death,
Yeah,
because you beautifully pointed out.
Yeah.
This is about hatred.
yeah,
This is really hatred
Yeah.
of the other.
yes, yeah.
Yeah, so mine isn't a question, rather a comment. So this was a particularly difficult presentation for me. I lost one of my best friends during my doctorate at Michigan State due to overdose. No one knew
Mhm.
that he had a substance issue. He was extremely high functioning. We were getting dual PhDs, and we had also promised each other to get into Congress so that we could yell "Go Green, Go White" as our filibuster.
Mhm.
And then on a March day after spring break, my friend's gone. People are telling me, and I thought they were lying. I was like, no, because we have a meeting with the president because we got to get stuff done. Like we have things to do. And they were like, no, Max is gone. And I'm like, from what happened? And they found him at house of drugs, foam in the mouth. He had overdosed on heroin. When I talked to his mom, he didn't have a heroin addiction. His actual addiction was crack.
Mhm.
Crack wasn't available in East Lansing, so with heroin, and that heroin was laced with fentanyl, and that ended my friend's life. So this was especially difficult. What I wanted to challenge us all to, is to reimagine who, to Alan's point, reimagine who these people are. Often when we're talking about substance abuse and these addictive indicators, we think the worst. We think it's a homeless person. We think it's a person who's down on their luck. We think it's a sex worker. We classified and characterize these people, while the people who are the most vulnerable are right sitting next to us in class, studying every day. They're giving talks. They're advocating for valid rights for, he was Chicano, advocating for people, didn't want our DACA students to be removed off campus. They're those people too, not just the other people that we consider the classical cases. And we started this memorial fellowship for graduate students at Michigan State. Before I left, that was like, we must do this so that people can study these lines of work, because this is the important stuff. This is how we start the destigmatization. But since then, I've been an advocate for including this in these diversity, equity, inclusion models, which it is historically left out, because we have this idea of what equity means, when equity actually includes these types of policies. These are the ways in which we get a Harvard to include what is the opioid
Naloxone.
in the AED boxes. We have to include these in our DEI. Our DEI conversations. This has to be a part of any conversation of equity, has to include how we address all situations, not just the ones we think are the flavor of the day, but they must include those who could possibly have addictions that we don't know about. We could have faculty members who are struggling. We could have students in the same situation. And it's important for us to, one, shine light, do presentations like this, again, which were very difficult for me to sit through. But it's important for us here as a beacon of knowledge for most of the world to be those who are the ones who are saying we must include this in our DEI models going forward. We must include harm reduction as a form of equity building in our models.
Yeah, I mean, thank you so much for sharing your story and in your friend's life. And I really recommend and think through this, like the phrase "every overdose death is preventable," and almost do a morbidity and mortality report on, on the structures, you know what I mean? Like, so your friend's drug of choice is this, what, it's actually cocaine. So why have we not addressed this? Why do we not know? What Max was talking about, lack of access to healthcare. In my own family, I have substance use disorders in my own family. And, what is that like to be, Chinese, there really is a widespread prevalence across class, across race. And there are health equity studies that show that Black women, in the naloxone cascade of care, a lot of people have it, but Black women who use drugs are the least likely to have it with them on site. Like it's an equity issue in this cascade of care. What are the structures and reasons behind that? Like we now know that there's a gap. Is it because, understanding those structures and why that is, I think I agree with you. It's a massive equity issue.
Great, well, I want to thank you so much for really.
Yes.